decreased papilla. You see, it's fully covered, and you can see that attachment loss and attachment loss here too. But this is anatomic recession ratio of 0.87, and it is fully covered. So there is an anatomy of gingival recession. So you cannot decide like, I love tunnel, I will do tunnel. No, tunnel is limited to a given geometry of the defect. So also you can see some of my analysis, even RT2 defect, you have a lot of increase since you are closer to the one, you have greater probability. And of course I have one clear conclusion. Higher anatomic recession ratio means closer to one, you have really greater probability even in recession type 2 with tunnel and connective tissue graft. But the critical threshold for fully covering the root is 0.77 for the tooth. This is of course within my small sample size, but it gives you a clear vision. So what does it mean, 0.77? If it is over it, the defect has good probability to go for tunneling. But if it is lower than this, for example, if it's 0.6, go for the coronary advanced flap. Because you cannot cover this area primarily. So I applied this knowledge into my implant site. So I calculated first the anatomic line, and I divide this value to the calculated part of the, now it is not a gingival recession line, right? It's mucosal dehiscence line. So it is also needs to be extracted as a good knowledge. And look at the number, less than 0.77. So I have no possibility to go for tunneling, at least to my knowledge. So I decided to go to our boss. Our boss is coronary advanced flap. And coronary advanced flap is not only a coronary advanced flap. It is much more than a name. Why? I would like to tell you a story of mine. When I was in the periodontology department, as a young gun, I want to do everything. I was seeing some of my professors doing the coronary advanced flap. I'm sorry for what I said. From inside of me, I said, oh, coronary advanced flap is an easy procedure. It's not a problem. I can do it. It's not a big surgery. It's not a heart surgery. But I'm sorry for saying that. To me, now I am wise. I tell you, coronary advanced flap, if you are doing it perfectly, you will do anything in the reconstructive periodontoplastic surgery. Because this is very hard. And now we see that I am right, because look at this last paper of Giovanni's group. Complication and treatment errors in root coverage. Look at one of the case of Giovanni. He perforated the area. Master of coronary advanced flap. It is not an easy surgery to me right now, because I'm wiser. We are working in very thin tissues. So my dear friends, don't judge immediately what you're seeing like I did. So this is very important to me, to not to see a scar tissue formation like this. Oh, thank you. And this will be, how do you solve this scar tissue formation? I think it will be a little problem. So let's come to our situation, right? How I'm going to treat this peri-implant soft tissue defect Of course, I go for the coronal advance flap, right? And with the coronal advance flap, we are starting with a horizontal 3 millimeter incision. Now it is connected with 2 vertical releasing incisions into this area. And now, do you remember our split thickness flap preparation? Yes, I do reflect my split thickness flap into this area. So we are going to merge this vertical incision with my horizontal incision. So you're going to see how nicely and beautifully I connect this vertical incision with my horizontal incision. So everything should be in split thickness. You can see now, I reflected the flap split thickness. But be careful, you have to repeat the same procedure, copying yourself. You have to start from the distal line angle of this neighboring tooth, make a horizontal incision, and after this, do you remember what I did around tooth? I cannot do around implants. Do you remember what I did? I grabbed my periosteal elevator and did the full thickness flap. Do you remember? All? You remember? In this case, if you are touching your periosteum elevator, maybe you are going to disrupt this healthy connective tissue attachment on the implant surface and you expose the rough surface. So please, this is my one-word conclusion for this surgery. Everything should be split thickness, period. Don't touch your periosteum elevator around implants if you are working with this type of soft tissue defect. So now it is time for me, for the first time, touch to my flap, because since you are touching very gently, you need to remove the attachment of the soft tissues very gently. I also would like to work and remove laterally. So you can see now our flap is flying towards coronal direction. Now it is time for me, what? To remove all of the epithelium and to expose the connective tissue under it. Do you remember? It's the same principles around the tooth. But if you don't know how to work around the tooth, forget about covering implants. Please, first step, cover the roots. Work around the tooth, because tooth is your friend from your childhood. But this is not a real friend. You have to be very careful. And you can see now, this part is also being removed under the flap. So, buccal flap should be perfectly clean. I go to palate to expose and get some connective tissue graft. And now, again, like I stabilized the mucoderm, now I'm using my resorbable suture to stabilize my connective tissue graft onto the deepithelialized exposed papilla. Please cut it very short, because this will be buried under your flap, submerged fully. That's why you don't need a lot of interaction to resorb it. That's why you need to make it very short. And now you repeat the same procedure to stabilize the connective tissue graft towards the distal aspect. So this is how I'm going to stabilize the connective tissue graft. Now it is time for me to go for the closure of the coronal advance flap over the connective tissue graft. I don't want any exposure of my connective tissue, okay? So now I'm using, again, a sling suture towards the healthy papilla. And now it is time for me to close the vertical releasing incision one by one. So I start from the apical aspect of the mesial side. Why? Did you see that the flap is towards the distal aspect. I want to first close this part because this flap has an orientation to run away from the midline. That's why you don't need to close first the distal. You have to evaluate your surgical area. Don't wear your horse glasses, okay? See the surgical area like you know everything. And that's why you are going to close the distal as a second step after you closing the mesial line angle, okay? Now it is time for me to close the distal papilla. But my dear friends, I see. I am not in the surgery in the mood of God. I say, yes, I did a mistake. And that's why I didn't remove this. Because I'm an honest guy. If I don't like a suture, I remove it. And don't put your ego in the surgical table, okay? If you make a mistake, try to cover it immediately. And that's why I removed this suture. And I redone again in a proper way to be able to approximate the wound edges as the perfect one. But now, distal is perfect. There is no blood seeping. But you see, there is a little blood seeping. What does it mean to me? It's a dead space. I will have a lot of clot there. So it will not approximate the wound edges perfectly. So it means like I don't close primarily. That's why you need to stabilize your sutures. Look at the beauty of the closure. Since like if I don't see the sutures, I see maybe there is no cut. Everything closed according to the plan. And you can see now, when I placed my provisional inside, you can see the perfect integrity of the gingival margin and the continuity, and look at the emergence profile from this implant-borne restoration. This is the healing. You can see perfectly how we are going to apply our graft under this coronary advanced flap. And you can see the beauty of the emergence profile in one single shot. You can go and see the improvement in soft tissue thickness, and you don't have any depth of the buccal flap. Everything survived. So in this aspect, you can clearly observe the primary wound healing despite two vertical releasing incision, and this is it. So after that, of course, do you remember the angulation of the implant? It was buccally displaced and buccally located. Now, of course, you need to create, like Dr. High style, prosthetics like it, individualized abutment. You cannot use standard implant abutment that you buy from the company. You need to make an individualized abutment. In this aspect, I would like to declare, if we are working around implants, prosthetics are so important. Of course, surgery is important. I don't say that. But in some of my country, I don't know, Vietnam, but in Turkey, everything is surgery. Surgery, surgery, surgery. Surgeon is the god, but prosto is like slaves. To me, it's not true. To me, surgeons are king, but prostos also king too. Periodontist maybe could be. But this is what we do. I try to be really minimally invasive. Since she didn't have any problem with the number 11, of course I paid a lot of money to my dental technician to make a beautiful restoration. It took 2 weeks to prepare this. And in the model you can see that I didn't touch this tooth. It is very hard work in terms of prosthetic. If Dr. Hai can confirm me, Well, because normally you would do a veneer here. It's the easiest job. But I would like to always walk in the hard path, because this is my way. Veneer, crown, and implant-borne crown onto the individualized abutment. So this is where we started, and this is where we ended up in time. So I also changed the angulation of the implant perfectly, and now she's, I think, very happy to see the results, where we started and where we ended up. You can clearly see from this beautiful comparison between the baseline and 1 year, you can see how nicely we changed the shape of the contour and eliminate an aesthetic problem of a very young lady, and she's very happy right now. And after 2 years, she visited me with the husband, so I'm successful. She married, okay, no problem for me to analyze, and you can see how beautifully she's smiling. And now, this is from another perspective, and you can clearly see, maybe, you need to find a really good dental technician to maybe save the structure of your natural tooth, because there is no difference between our crown if it's done perfectly when we are making it in a real natural way. But we need to discuss some of the options. Is it stable in time? Because many of those times I hear the question of, you are doing the surgery, but is it lasting? Or it's just showing for 1-2 years, and is there any long-term stability? Of course we have. Giovanni showed the percent coverage is increasing in time. It's stable in 1 year, and it is even more stable in 5 years' time. You see the improvement, and improvement may be also happening because of the adaptation. But it is not only the Giovanni Zucchelli's work. Mario Rocuzzo, also from Torino, confirmed the results with the tuberosity graft. And also both of them successfully covered the dehiscence, and also very well maintained at 5 years due to the maintenance and stability. If you are seeing the patient regularly, and if they are cleaning perfectly, you see the maintenance and stability for sure. And of course, we need to analyze what we have as a data with the excluding the connective tissue graft. But please, my dear friends, this needs to be read very carefully. Look at the title. Porcine-derived isolator dermal matrix, refer mucoderm, for buccal soft tissue augmentation. Okay? Soft tissue augmentation. What does it mean? Meaning that I can get fat, but I cannot be taller. Okay? This is it. I can be like sumo, Japanese sumo, but I cannot be Michael Jordan. Okay? If you want to be Michael Jordan, you have to use a connective tissue graft, because since you want to be taller with the flap, you need a stabilization. And only way is connective tissue graft. But if you want to be like the sumo, you can get mucoderm with a good result. And this as a study needs to be taken care of rather carefully, so you can see the problems of in horizontal way. You see the application of the mucoderm from the side, the same hydration with the sterile saline, stabilized with the suture, covering the defect as I showed to you, and you can see the increase in time. And I know this case personally, it has also 7 years stability. I couldn't show you, but in 7 years' time, it still stands and stable. So these results are confirmed by applying perfect primary closure, okay, with mucoderm. Don't forget. And I would like to confuse you, or maybe enlighten you. Soft tissue thickness is 1.2 millimeter in thickness increase in horizontal dimension if you apply the surgery meticulously, perfectly, right? I would like to show you another data. This is also the same. Mucoderm and connective tissue. And I would like to show you the results. 0.3 for mucoderm, for the connective tissue graft 0.8. When you see some difference from previous literature 1.2 and this one is 0.3, then maybe you need to get a Hanoi beer and to think on the results. I would like to go back, okay? I would like to go back again. What could be the problem? Do you see the secondary wound healing for the mucoderm group? Is it fully closed? Or do you have a secondary wound healing? So, my dear friends, from this study, I drink not Hanoi beer, but some beer in my town, and I read this literature. And I said, okay, primary closure is key for substitutes. Because one is getting 1.2, and this group getting 0.3. Why I'm going to buy 0.3 mucoderm if I don't do a good surgery? So this is very important to understand and analyze all the data very carefully. And of course, let's go back to the beginning. We want to save every tooth in the world, but it is not possible. What happens when you lose a tooth structure? We all know that we have changes. And changes are depending on, of course, extracting the tooth. And extracting the tooth caused by what? With this one. If you don't do anything, or if the tooth is extracted by someone else, or if the patient lost due to trauma, you will lose the dimensions of the papilla for sure. Papilla loss for sure. But I would like to show you another way. Don't only think from the front. Let's change the angulation. And look at the dimensional alteration if you don't do anything. Up to 6 millimeters of dimensional loss. And if you're going to make an incision here and reflect the flap for implant placement, you need to rebuild first the bone, right? And then you need to reconstruct the soft tissues. Then you may be successful. But I would like to show you what can happen to a natural point of view. This is the study that everyone is talking about, buccal bone resorption. Everyone. I don't want to talk about this. Do you know what I want to talk about? I want to talk about palatal bone. Look at the palatal bone. I wish we could be like this, like vice versa. If I want to see the patient from the throat, it will be perfect. But we have to see the patient from the buccal aspect, unfortunately. And look at the palatal wall, it still stands intact. While you have the problem in the buccal, because you have this problem. The problem of having a thin versus thick buccal bone thickness. Because of, look at this. Do you see it? Less than millimeter, completely resorbed. But if it is more than a millimeter thickness, it stays there. What I told you, remember? What I want to talk about? I want to talk about palatal bone. Look at the palatal bone. Do you see any difference? No. No. Palatal bone is staying there because it's thick enough. Despite the trauma of the extraction, We didn't lose anything. So, to us, it is so important to analyze the mean thickness. But what is the mean thickness of the facial bone when we analyze it? And this is a very precious study done by Brazilian Januario group. And they analyzed the anterior maxilla, central, lateral, and cuspid. And when we analyze our precious tooth, which is a central incisor, I love every tooth for sure as a periodontist, but some of them has some priority, right? Central is the most frontal one. And when I see you, I see your two eyes, one nose, two lips, and two central for sure. In aesthetic. And also two eyebrows, okay? For girls, I say eyebrows are so important, I know that. But central, 1 millimeter apical, what is the mean thickness? 48% is in between 0.1 and 0.5, and in 38%, it's between 0.5 and 1. The total sum of this is 86% of our patient in the maxillary central incisor has thin. So we are dealing with real problematic area, real problematic due to anatomic conditions. This is really a problem for us. And when you see after your extraction, you can easily see the thickness and the resilience of the buccal bone. You can see that it's so thin. So we have to do something to protect it. And of course, within time, what happens to this extraction socket? We have different healing modalities and healing perspectives. First, we have to think what's happening inside. Second, what's happening from the outer aspect, and what's happening also from the soft tissue perspective. And this is the diagram that I took from Jan Linde. So, from the inside, the bone fill is increasing in time, but from the outer aspect, the bone contour is decreasing. But from the soft tissue perspective, we have a different perspective. It closes in 6 to 8 week times and stay the same. So to me, soft tissue is just a matter of closure and no changes in time. But what changes over time? Inside, which is the bone. So that's why it is so important to understand when and how we are dealing with missing tooth. Type 1, of course, is my favorite. But to me, from this scale, I have only 3 clinical scenarios in my practice. Only 3. Which is, when I do the tooth extraction, I can place an ovate pontic, like prosthetic sealing concept, like Dr. Hai's department, prosthodontics. Or I can do ridge preservation. And if I have a possibility, an indication, I love to place immediate implant. And last but not least, my third scenario is patient already go somewhere, the guys extracted the tooth, did nothing, and I end up with atrophic ridge. But today, I would like to discuss with you if we can have the possibility of applying a material that is very close to understand this problem. This is our problem. And it is not a regular immediate implant case. It looks like we have a tooth, but from another perspective, you lost everything. It's a very deep crack under this palatal area. So what I'm going to show you is the CBCT. And this is a very good case in terms of teaching and didactic point of view. Why? Because of it contains extreme knowledge. Let's analyze one by one. What do you have? Sinus. What do you have? Almost no residual bone. So if I'm going to place my implant into the healthy bone, I will use this angle, And prosthodontic friends of mine going to take the gun and in Turkey, you know, the best way, fast, end of the problems, you know. I reach to God, but I cannot do this. I want screw retained crown because I'm periodontist. I want to remove the crown if there is a problem and use it again. And that's why my way prosthodontically is not to place like this direction, but I want to go as pleasing my prosthodontists, okay? But in this way, I also want to show you that we have two different bone phenotype on the buccal aspect. Look at the continuity. On the most coronal aspect, what do you have, my dear friends? Thicker than a millimeter. There's this part, you see, thin buccal bone phenotype. And what I have, a palatal bone loss. Okay, I have problems, I know that. But the real issue for this case, to extract the tooth in one piece. But how I am going to stabilize before entering into the sinus? Because I don't want to touch the sinus. Maybe I can engage my implants, not from the palatal bone, but maybe the mesiodistal bone, if the structure of this tooth allow me. And I go with my periodontal probe after the tooth extraction and I measure it. It's 3 millimeter in width. So I can place my 4 millimeter or 4.2 millimeter implant without any issues. So I'm going to place my implant laterally stabilized, but buccolingual, I'm going to fill it without any problems. So you can see, I think, the success of mine, not placing an immediate implant in my opinion, but to extract this tooth in one piece without breaking it. Do you remember the break in the palatal area? It was really, to me, when we are talking about immediate implants, I think immediate implant is master of tooth extractions. If you do it perfectly, you can really make a perfect immediate implant because you preserve all the tissues. But if you do a shitty extraction, forget about the benefits of or beauty of the immediate implant, at least in my point of view. That's why I placed my implant stabilized in the lateral walls. And now it is time for me to discuss with you, do I need any connective tissue graft? Because you see, I'm able to take a connective tissue graft. I'm a periodontist. But I'm not an obsessive periodontist. I have different obsessions, but not a periodontology point of view. I am working for the benefit of my patient, not the benefit of my ego. So when I place an implant intact, why do I need to go and create a pouch and go on the palate and place a connective tissue graft? That's a sad story for the patient. That's why I would like to show you another opportunity. Maybe you already opened your bottle of Cerabon, right? You opened the bottle because you need to graft the gap. You already still some empty particles, right? Within your surgical tray. So maybe I would like to show you the way that maybe we can place our graft not to the top, but leaving some space. Do you remember? Not to overfill from my periodontal knowledge. So I leave a little space. This part is not for bone reconstruction. This is for scaffolding effect. It will work as the same principle of connective tissue graft. Not maybe you're not going to create a connective tissue graft, for sure. But the idea, why you're placing a graft there? To stabilize the tissue there, right? Not to see the shrinkage of the tissue. So maybe this is your way, and it's called dual zone socket management. This is the technique of Dennis Tarnow. I highly respected this idea. That's why I bring into my clinical practice. Otherwise, I would end up like every obsessive periodontist, like, oh, I open up the flap, I will place a connective tissue graft. Yes, I placed a connective tissue graft. You see it, right? I'm not unable to do that. But we have to work for the benefits of the patient. I would like to repeat again, not boosting my ego, okay? So you can see that I'm going to use the provisional restoration, and this is immediately after surgery. You can see that I didn't enter into the sinus floor, as I told you. I engaged my implants in the lateral walls, and you can see some of those particles after for the impression taking. What I can recommend you, maybe you can just touch with your instruments. If it's loose, you can remove it. But I have never seen any infection for this reason. But I would like to share with you also this phenomenon, what can happen when you apply a xenograft. Of course, I would like to mill a lithium disilicate restoration. I put it in my oven, and then you can see the crystallization point of view, but I will never use any glazing under the mucosa. It will be only polished for soft tissue adhesion. If you place a color material under the mucosa, it will create a disintegration with the material, so it's not biologically compatible. Please also remember this very well. So, I will make the luting procedure outside of the mouth. You can see that still we have some remnants. That's why I would like to show you even what can happen if you cement in the mouth. Now it is time for me to clean with my air polishing device. It has a glycine powder, not very hard. So you can see a very clean crown abutment is ready to be placed and tried into the mouth. So, but I would like to show you that after the torquing, of course, use the recommended torque values from your implant company. But look at the beauty of this. Did I use any connective tissue graft for this area? No. But look at the beauty and look at the continuity of the buccal mucosal contour. Look at this area. This is really, really a perfect news for the younger generation trying to be minimally invasive, not a maximally invader, you know. And I would like to show you what can happen in time to our area. I would like to show you this part. Please focus the fate of this buccal bone and the coronal part. Let's start. You see, in time, you see a little bit of shrinkage, but not totally resolving. But in the middle area, entire thickness is gone. What do you have now is pure cerebone. It's amazing to see this comparison. So, in one case, I showed you the beauty of reconstructing the area, but also I would like to show you the contour changes I protected. I showed you already in a clinical video, but look at the path. You see the potential? You see the potential of internal grafting. And you see also the bulk of the tissues that I created with my dual zone socket management. I think it is a very good case to analyze what we can done in time. But some of you may say to me like, you are lucky because you have one tooth. You know, you have two periodontal ligaments. You are periodontist, you know this. Don't trick us. But believe me, my dear friends, even the EAO, Uli Grunder asked to my friend Stavros Pelekanos and he couldn't answer, but I have the answer for you. What happens if you have two missing and if you have to replace two central incisor in the aesthetic zone? What you will do? This is a lady in the 60s. She's a medical doctor. She's sent to me by an endodontist friend of mine. Endodontist said, I cannot save these tooth structures. You need to extract and you need to place an implant. And I would like to show you the problems of it. Do you see the discoloration due to the metallic restoration, and also maybe the component of the tooth is a dark substrate so that you can see a shimmering through effect of bluish, purplish appearance, and there's a discoloration. The color didn't match, and she's very concerned about her smile. And you can see also what is my problem. That's why I told you every tooth is so important for me, but centrals, it's the most prominent tooth in the arch. If you make mistake with the laterals, believe me, it won't be a lot of problem. With the canine, yes, it is also a very prominent tooth too. So to me, lateral is a rather easy tooth compared to central and canine. The hardest part is to replace centrals and canines. And today I brought you the case of the central. You can see both 11 and 21. You see a small fenestration type defect, but there is no dehiscence type defect, but a small infected part. It's a chronic infection due to endodontic problem. So when I remove the tooth, I will remove the origin of the disease, right? But I have to be very careful. So what I'm going to do, are you going to extract two tooth immediately? I personally don't. Do you remember I first opened the buccal flap, clean everything, then I reflect the lingual flap. It's the same here. Sometimes I'm C-surgery. Remove central. Remove the other central. Why removing the other central? Immediately. If I want to kill, I want to kill one by one. Not doing this. Ta 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 ta. We have to be calm. Just kill one. Okay? Then try to resurrect, to give another life. So I try to give another life, and also you can see the inside structure of the tooth, so you can see that it's a very soft material and a very decayed one. So please don't even think to make socket shield for this case. Socket shield, you can do a very intact tooth, okay? This is a little bit of infected part. So we need to remove, but we need to remove gently. I need to gently dissect in the buccal palatal orientation, and then I am going to remove one by one. Again, first I'm going to cut, then remove piece by piece. Do you remember my words to you? Immediate implant is the art of tooth extraction, or starts with the art of tooth extraction. Please look at the papilla. It's so intact. And if you cannot extract the tooth like this, you don't see the benefit of placing an immediate implant. And I removed everything. I installed my implant. I did the same procedures as I showed you with the dual zone socket management grafting. And you can see that I am now going to kill number 21. This is now my time. Now you can see the removal of the chronic infection, and you can see the placement of the implant, and you can see now the beauty of this, but I think I would like to show you in another way. This is the dual zone socket management for neighboring tooth each other. Just not like a single tooth extraction. Is like I extracted the two centrals and try to still maintain the volume without going for the connective tissue grafting. I think this is really important to understand what's the effect. And when I showed this case to another friend, I would go for the connective tissue graft. Okay, you can go for the palate of your patients. But let's see what we can have in time. And this is the provisionals. And after this, you see baseline image and 1 year after. And you can clearly see this comparison, the changes in the buccal aspect. You don't see a lot of resorption. The tooth positioning is in favor of us. If you have a lot of recession on the centrals, maybe you could go for the connective tissue graft, for sure. But if you have already a very good levels of margin, why do you go for the connective tissue graft for those cases? So you can also see that we eliminated the discoloration of the mucosa, and also I placed two veneers for the lateral incisor, so we can create the harmony of the patient. So also I would like to share with you the CBCT comparison with the retracted lips. You can see our soft tissue dimensions and also the bony dimension. It is a very stable tooth and it is perfectly reconstructed. But I would like to show you the problematic one. Which one is 21? Do you remember the fenestration type of defect? Yes. And now, maybe some of your critical eyes say that, oh, doctor, maybe you have some opening here. Okay. Maybe you don't see it from the CBCT point of view. Or let's think that if there is no bone here, where is the entrance to your bacteria? Where is the entrance of the bacteria? Bacteria enters from the sulcus. Or if you have a mucosal dehiscence, then the bacteria may enter. But look at the distance from this retracted CBCT. So the most important aspect for us as a periodontal point of view is the entrance through the restoration, right? So if you're seeing this successfully, so I think there is no need to discuss these small, maybe apical implant exposure, maybe. So, but to me, if the implant is exposed into the sinus, could be a problem, which I saw many cases. Some of the patients have some problem with the metallic allergy or stuff, but mostly also they don't encounter any. But for us is not to expose the coronal rough surface of the implant. So this is very critical in terms of periodontal point of view. But I would like to show you how nicely we preserved the integrity of the buccal central incisors. And also I would like to show you the comparison of our CBCT. I didn't apply any connective tissue graft. I just gapped the graft with Cerebon particles, and you can see the perfect continuity of the buccal aspect with the right positioning of the implant. And from another perspective, you can see that how nicely we preserved the contour on the buccal aspect. Do you see any connective tissue graft under this? No. I just used the principles of Dennis Tarnow, which was the dual zone technique for this. And also sometimes I'm hearing from the speakers, I left the space, it will fill automatically. I will show you, it will not fill automatically. It may fill, but please don't promise to patients. I would like to show you, and please concentrate, this is 1 year, just concentrate here. In 3 years' time, you see only minimal increase. Minimal. 1 millimeter. No more than this. And maybe if you are really allergic to black triangular space, maybe you are going to change your contact using the prosthodontic principles. But since my patient is around 60, 63 years old, she said, this is very natural looking for me and I don't need anything because you're seeing black triangle, I don't see. Because this is a photo that I'm taking with removing all the saliva by drying the root surface. But normally, she has saliva. And when there is a saliva, these small interproximal embrasures will be filled and illusionally it will look like an intact interproximal papilla. So you can apply all of your techniques within the range of the Botis indicated system. And also I would like to conclude my presentation. We need improved wound stability for sure. If there is a stability problem, we will not regenerate the area for sure. And we are not saying that biomaterials are magic. Yes, they help, we love it, but we need to respect the biological principles. You cannot say, like, this Botis biomaterial doesn't work. Maybe it doesn't work in your hands. Did you use the same technique? Did you apply the correct technique? If you don't, biomaterials is not helping, of course, but also connective tissue graft or autogenous bone also doesn't help. Last but not least, we need to, if we lose the tooth, I hope not, but if there's a missing tooth, we need to take into consideration the use of right timing for implant placements and tissue management. You know that my favorite is immediate implant, but if it is not indicated, never ever apply immediate implant. Go for the safer direction for the patient safety, and all of these should be protected with our precious soft tissue. Because if you want to create bone, who is going to protect the bone? Our soft tissue, like this. If you have problem with the soft tissue, if it is exposed, then we are not going to see as a pure regeneration. It will be a partial fill, and I believe soft tissue will always remain the real issue. And for your time, think am I.
Thank you so much, Professor Dr. Serhat Aslan, for your so informative sharing. And now is the Q&A time. Xin được cảm ơn những chia sẻ hết sức bổ ích đến từ giáo sư bác sĩ Serhat Aslan. Và ngay bây giờ thì chúng ta sẽ có khoảng 10 phút cho phần Q&A. Nếu như quý bác sĩ nào có muốn đặt câu hỏi trực tiếp bằng tiếng Anh dành cho báo cáo viên thì có thể giơ tay ạ. Ban tổ chức chúng tôi sẽ di chuyển mic đến phía quý vị.
Đặt lại. Anh đặt cái gì?
Vâng, nếu như không có câu hỏi được đặt trực tiếp thì sau đây chúng tôi xin được trân trọng kính mời bác sĩ Trần Ngọc Hải sẽ tổng hợp và đặt ra câu hỏi dành cho báo cáo viên của chúng ta. Xin mời bác sĩ ạ.
Okay, the first question is if we have the bony defect from both sides of the teeth, how we can do the entire reserve papilla flap?
You are the question?
I'm translate the question from the.
Okay, please start again. I want to see
Okay,
you.
the first question is if the tooth have a bony defect from both sides, mesial and distal, how we can make the.
If it's not a
entire-
molar tooth, if